Most of the liver-directed therapies we offer involve some sort of embolization. Embolization means putting something into an artery to block it off. That could be temporary, that could be permanent. We'll start by giving a brief review of immunoembolization and then go through some of these other therapies, such as radioactive microspheres, chemoembolization, percutaneous hepatic perfusion, and ablation. Photomustine infusion is included on this. Photomustine is a type of chemotherapy agent. It is not approved for use in the United States. It is not available for the United States, so we won't be considering that as part of this talk. This is a table that Karin Gonzalez had put together a number of years ago, just kind of organizing studies describing chemoembolization up to that point. And you can notice a couple things. Number one, with the exception of the one on the bottom, they really are pretty small. And two, the survivals as seen. Yes, as I was instructed, that the pointer does work if you press the button hard enough. I don't know, but I was afraid of like messing up the slides or something. And the survivals are uniformly, unfortunately, pretty dismal. So let's talk about some things that work better than this. So immunoembolization was developed at Jefferson initially as a thought to try to improve survival, but also noticing that in a prior chemoembolization trial, there was this subset of patients who, if their liver tumors did well from the treatment, they would still end up developing metastases at other sites of the body. So the thought is that it's mainly the embolization, the blocking off the blood flow, because liver metastases derive their blood supply from the artery system, whereas most of the rest of the liver gets most of its blood supply from the portal vein. That's the big vein bringing blood back from the spleen and the bowels and the stomach. So if you block off the artery, hopefully that will cause some of the tumor to die. When tumor cells die, that starts inciting the immune system. And then if you add an immune stimulant in there, maybe you can get more of an inflammatory response and start trying to train the immune system to, hey, maybe we can start recognizing these tumor cells, and from the memory part of the immune system, try to learn that and recognize them. The predominant agent we use is called GM-CSF, granulocyte macrophage colony stimulating factor. It does a bunch of good things to make the immune system work better, particularly in stimulating the macrophages, and dendritic cells are little things that go and look for tumors and other annoyances in our body. Why this agent? This is an elegant study from MIT, published in the early 90s, a long time ago. But anyway, looked at a bunch of mice with a bunch of different tumors, and then which of these cytokines worked against mice with different tumor. And the one combination that stuck was GM-CSF in the mice with melanoma. And it was specific to that. When they tried then using that in the other tumors, it didn't work, and so it was very worthwhile. So that led to a phase 1 study from 2000 to 2004, and basically the GM-CSF is emulsified, mixed up in an oily contrast agent, kind of like the contrast you get injected for a CT scan or an MR, but a very different agent. For one thing, it's an oil, it's viscous, it's thick. And tumors tend to take up this oil, and therefore the drug, it serves as a drug delivery vehicle because that gets into the tumors, and it's viscous, it gums up tiny blood vessels within the tumor. We follow that by gel foam, kind of like a mashed up sterile styrofoam, which temporarily blocks off the arteries. But anyway, what we would do is treat one side of the liver, about 4 weeks later, treat the other side of the liver, repeat the CT and the MRI about a month after that. If the patient's doing okay and it's working, keep going. So what we learned from this is that about a third of the patients at some point, the tumors either got a little smaller or, in a couple patients with limited disease, went away. About a third of patients had stable disease. And so again, you have to go back almost 15 years and also compare this to what was out there with chemoembolization, and gave us the idea that, hey, this might be onto something. And this is an example of a patient treated with immunoembolization. This is the artery going to the liver. These are tumors. And when he came back 2 months later, you can see much less blood flow to those same tumors. And that's, at least at this point, largely a result of the embolization. This is just a later phase of that arteriogram, watching later on as the contrast is concentrating more in the tumor. And then when he came back 2 months later, there's still the tumors are not totally gone. The tumors are not totally dead. There's still a little bit of hypervascularity, a little bit of blood flow around here, but certainly better than it had been. And what we discovered is that patients undergoing immunoembolization, it took longer for them to develop tumors outside the liver, which I know isn't the primary problem, but kind of adds some evidence that, hey, maybe we're teaching the body here a little bit what's going on, and that's trying to help suppress the tumor. When we compared patients undergoing immunoembolization at a higher dose to a different group of patients who had undergone chemoembolization, we did see that there was a longer survival with the immunoembolization patients, and also, again, took longer to develop tumors outside of the liver. So I just want to keep this going in the interest of time, but we also saw some patients who tumors continued to shrink a bit after they got a break from their immunoembolization. And this has to be looked at as a maintenance program. It's not a once and done, like getting your appendix out, your appendix is gone for good, you never think about it again. This is a maintenance program of repeated therapy to be effective. This led to a randomized trial comparing patients getting immunoembolization and bland embolization. Pretty much similar criteria. And what we saw is that both were safe, both were well tolerated. Side effects from these treatments can be some nausea, some vomiting. Some patients have pain, but pain can be treated with pain medicine for a short period of time. Similar with medicines for nausea. Just kind of feeling icky for several days up to a week. Side effects tend to be worse after the first 2 treatments than subsequent treatments. This again showed that there was an overall survival benefit in patients who had 20 to 50% of their liver replaced by tumor. Unexpectedly, in patients with just a tiny amount of tumor in their livers, the tumors actually grew despite what we were doing. And it turned out that there was likely a suppressive or paradoxical response to the highest dose GM-CSF. I'll get back to that in a moment. But anyway, you can see that, compared to some of the earlier trials, again, survivals are starting to creep up here, not saying it's good enough, but we are making some progress here. And we were able to show that patients who had increased levels of certain immunologic factors in their blood after the procedure correlated with a better outcome. So we looked back to try to figure out, okay, so why did these patients with the tiniest amount of tumor not do as well? And we went back and realized that of the 2 high doses we had been using over the years, probably more isn't always better, and the lower of the 2 seemed to have a more consistent benefit. So, as I say, it took us about 14 years to figure out the appropriate dose, but hopefully we're there now. We have looked at a group of patients. Certainly immune checkpoint blockade therapy is of significant interest. There were 27 patients who were treated with both immunoembolization and ipilimumab at about the same time. Almost all the patients in this group were starting both treatments, frankly, most of them within a week of each other. And unfortunately, that didn't have any effect on delaying extrahepatic metastases. I misspoke. Most of the patients still developed extrahepatic metastases, so ipilimumab certainly wasn't preventing that. But at least as a pilot study, it showed that it is safe to combine these two therapies, which we didn't know that. The downside is that it added typical toxicities of ipilimumab to patients undergoing immunoembolization. So those were new issues for us to deal with. I talked about that oily substance, lapiodol, that we mix the GM-CSF in. And here you can see an MRI pre-treatment of a patient with a tumor, and you can see how the lapiodol really concentrates in the tumor. And in some other diseases, that concentration is actually used as a marker for that. We've been observing for a number of years that there's a subset of patients who thankfully do really well from these treatments. This is an example of one of them. Someone who started immunoembolization in October 2010. He probably had 40-some treatments over the next 8 years with intermittent breaks. I mean, yes, one can say that this tumor got bigger going to that tumor, but the times of growth were always when he was on breaks for 6 months to a year. And one of our residents has been looking at this and looking at a group of patients initially treated with immunoembolization over a 9-year period. We've learned that about 16% of patients have prolonged survival of more than 3 years, and they get treatment breaks. And as I said, we now have patients, admittedly a small number, but we have patients out 4 years, 5 years, 6 years, 7 years living with this disease, still being treated with intermittent immunoembolization treatments. Unfortunately, that doesn't work for everyone, and about a quarter to a third of patients initially treated with immunoembolization will progress despite that therapy. And here you can see where little dots in the liver turned into much bigger tumors. So let's go on to discuss some other treatments. First, we'll move on to radioactive microspheres. These are tiny radioactive beads coated in yttrium-90, which is a radioactive substance. So the goal is to inject these tiny particles through the artery into the liver, have them lodge in the liver tumors, and emit their radiation and destroy the cancer cells. Just a typical treatment of the right lobe of the liver would be administration of 10 to 20 million of these tiny particles, just to give a sense of how really small these things are. I'm kind of focusing on the Jefferson experience with this because the handful of other reports out there have only very small numbers of patients over very long periods of time. We started treating patients in this manner in January 2007, purely as after patients had already failed some other therapy, because we didn't know if this was going to be effective at all. And as part of this, we learned that patients with more tumor, that this wasn't so helpful for patients with larger tumor burdens in the liver. But at least at this point, it was adding a median of 10 years to survival. And as I like to say, we have these multiple treatments, and it's like different arrows in our quiver. And certainly adding this arrow was another major extender. Most patients, the tumors stayed about stable, but in a third of patients, they grew anyway. One of the radiation oncology residents did sort of a follow-up of a larger group, and what was interesting from this was now we're seeing that patients are living 2 years from the time their metastases were diagnosed, which this was, again, not good enough, but we're making progress compared to that chemoembolization table I put up at the beginning of this talk. So Karin Gonzalez organized a study looking at 48 patients treated with radioactive microspheres. Half of them were treatment naive, meaning this is the first treatment they had for their liver metastases. The other half all progressed after immunoembolization. So looking at the group that started out using treatment, you can see that actually a large number of the patients, the tumor stopped growing. They either shrank a bit or they stayed about the same. So we're accomplishing something. However, at a median of about 8 months, remember the definition of median is half do better, half don't do as well. So at about 8 months as a median, but in some patients out to almost 3 years, tumors would start growing again in the liver. All patients who progressed developed new metastases. So it's not that the radiation didn't kill the tumors that were there, it's that the cells were still there and or got redeposited and new tumors formed. The group who started out with immunoembolization overall had a bit less tumor. Not quite as many of them had stable disease or better, and some patients who progressed through immunoembolization showed us that they unfortunately progressed through radioactive microspheres too. But we're again showing, while this wasn't statistically significant as a comparison between the two groups, but patients who started treatment with immunoembolization and then went on to have radioactive microspheres as part of this trial are, again, half of them are getting to the 2-year mark, and notice quite a long tail of patients living out longer. My hunch is that some point, way in the future, we kind of see a small group of patients, perhaps about 10%, who unfortunately, for reasons we don't know and reasons we can't predict, don't have much of a response pretty much to any of the treatments that we do. Again, if we could predict some way, somehow, who fits into that group, that would be very helpful for the patient and for us. There seems to also be, on the other end, a group of probably about 15% of patients who seem to do really well with almost whatever we give them and have a couple years of survival with every treatment. And again, we have obviously we'd love everyone to be in that group. We have no way of predicting who those superstars are going to be. I include this because, again, a lot of interest in immune checkpoint blockade therapy. So MGH looked at a small group of patients retrospectively who were treated with both radioactive microspheres and then subsequently received a variety of different immunotherapies. While this isn't comparative, survivals are in the same type of ballpark as what we've been seeing with liver-directed therapy in our institution. There is a multi-center trial going on at 3 institutions for treatment of liver metastases using radioactive microspheres plus ipilimumab and nivolumab. I should have also mentioned that there's a trial in our institution with immunoembolization plus ipi and nivo, but that's for the clinical trials panel to discuss afterwards. And certainly, radioactive microspheres can be very useful in shrinking tumors, and this is just one example. But unfortunately, some patients fit in that small group of they progress despite our best efforts. And this is a patient's tumor prior to treatment with Surspheres, and this is only 2 months after Surspheres, after he had rapidly grown through immunoembolization too. So again, just as a reminder before we move on to chemoembolization of where we used to be, and this is probably the largest experience I'm aware of from MD Anderson, again, over a very long period of time. almost all patients receive cisplatin as a chemoembolization agent, but then half the patients also got an arterial infusion afterwards. One thing helpful about this article is, as we've been doing, is stratifying patients based on how much tumor you have, because a lot of these older articles, if they have a dozen patients, it's everyone with uveal melanoma gets lumped together, and the person with one tiny 1 centimeter tumor is very different from someone with much of the liver replaced by tumor. This series had a relatively high complication rate, many of which are severe. Much of that was due to the arterial infusion that was given afterwards. And compared to the other treatments I've been showing you, immuno embolization and radioactive microspheres, the survival is pretty dismal, above 25% of the liver replaced with tumor. And again, we're certainly not using chemoembolization as a first-line therapy for patients with limited disease. Again, Karin looked at our patients who presented with with at least half their liver replaced by tumor. This was from 2004 to 2011. Thankfully, we don't see this much anymore due to much more use of screening. But it was more common in the prior decade, and even patients showing up with that much tumor, we were still able to show a median survival of 7 months, or more importantly, almost a quarter of the patients living at least a year. This is an example of a patient with just a huge tumor, but after 13 months, still trucking along. So patients can be stabilized using these therapies. Another patient treated with chemoembolization, just nicely showing the oil concentrating in the tumor afterwards. And there again, it dragged the chemotherapy into the tumor. This tumor was missing, but when we came back to treat the other side of the liver, then that tumor also has the lipiodol uptake. And both those tumors partially died. Drug-eluting beads is a newer technology for administering chemoembolization. Basically, the beads marinate in chemotherapy overnight and are then injected in a similar manner in the hepatic arteries. There have been several studies from Italy using a drug called irinotecan that have shown kind of surprisingly good results. We've treated a number of patients using irinotecan about 10 years ago, and not quite 10 years ago, I apologize, and we were not able to have the same experience of success that they were able to report. On the other hand, we have looked at patients treated with adriamycin, a different chemotherapy agent, loaded onto these drug-eluting beads. And based on a multi-center trial we had participated in about 8 or 9 years ago, we learned that, hey, these things really seem to work well for patients with big, bulky tumors greater than 5 centimeters in particular. And what we learned from this is, again, these patients all had big tumors, but what we learned from this is that this treatment works well for patients with discrete nodular tumors, distinct tumors in the liver. It did not help so much for patients whose tumors were of a more infiltrative nature. And the difference in survival between nodular tumors and infiltrative tumors has also been suggested by others. This first paper includes skin melanoma patients, which is a part of why the disparity in the overall survival. Both these papers are from the same group, but these are patients just with eye melanoma, and they were trying to associate the difference in this pattern with some of the chromosomal differences. When we looked at more patients who were big, bulky nodular tumors treated in the same fashion, Notice that we're getting up to median survivals of a year and a half, but we have a number of patients, again, living out 6-7 years with this treatment. So we followed it. We learned early on that you can't keep giving the beads again and again and again and again. It just beats up the arteries too much. So we learned, switching over to BCNU chemoembolization, as I had shown you previously, can be effective as a maintenance therapy to continue controlling the tumors. A patient with a clearly defined tumor who was treated with these drug-eluting beads. Actually, this was on part of that clinical trial we did where you had to keep giving beads, and it ended up that, ended up that the whole right lobe of the liver kind of shrank down. The left lobe grew dramatically to compensate. As part of that trial, we learned that if you give too many beads, you can end up with little bile lakes in the liver, which can cause fevers and pain. So from that point, we learned don't give as much. But this is just an example of a patient with a big bulky tumor that a year later had shrunken down. This is the arteriogram of that same patient. She actually had 2 big tumors which had very little blood flow going to them later. And she actually survived. She probably survived 5 or 6 years without having further liver-directed treatments. This is a patient of Caron's again, where you can see big tumor shrinking down. Percutaneous hepatic perfusion, also known as the Delcath trial. This procedure is developed in an attempt to replace an older surgical procedure that's a major abdominal operation to perform the same goal of isolating the blood flow draining from the liver and infusing a high dose of chemotherapy. So, as the company slides tell us, PHP uses 3 primary principles. 1, blocking off the main vein in the belly, so you're trapping the blood that's draining out of the liver, infusing melphalan, an old chemotherapy agent, and then, so basically you're infusing the chemotherapy in, you're sucking it out, and you're running it through a pair of filters before giving the filtered blood back into the patient's neck. This is their famed double balloon catheter. Here are the 2 balloons up in place in the inferior vena cava. These are the hepatic veins with contrast injected to show that we don't have any leak going up into the right atrium. And there's the catheter that is used to infuse the chemotherapy. So the trial is still ongoing. The group from both Moffitt in Florida and Southampton in the UK combined their experience to tell us retrospectively how their patients were doing in the time period between the 2 trials, the prior trial and the current one. And notice that, unfortunately, this isn't making all the tumor go away. Well, some patients have had a truly remarkable response with this. A third of the patients, the tumors progressed despite going through this, and more treatment-related toxicities than encountered with the other liver-directed treatments I've discussed. They describe a median overall survival of 15 months, which is, without knowing some of the specific characteristics of how much tumor, what percent of the liver is replaced with tumor, it's a little hard to compare, but it's certainly not knocking it out of the park compared to the other treatments we've discussed. And there are a number of potential side effects and complications that we haven't been seeing in other treatments. By the same token, we have to acknowledge that there are some patients who've had a dramatic shrinkage of their tumors by undergoing this therapy, and it likely remains one of the arrows in the quiver. The trial had been started as a comparative trial. You either got PHP or you got the best alternative care, which in our institution was considered chemoembolization. They didn't allow radioactive microspheres or immunoembolizations. At other sites, it was systemic therapy, immune checkpoint blockade therapy. Enrollment in the trial was slow, and the goal was to accrue 240 patients, 120 in each arm. Trial enrollment was slow. The FDA allowed the company to change the trial last summer to just treat 50 more patients using PHP. So that's where the trial stands now. Patients undergo this treatment every 6 to 8 weeks. Imaging after every 2 treatments, requires overnight stay in the ICU after the procedure. Again, patients need to have less than half their liver replaced by tumor, and very limited or no tumor outside of the liver. These are the centers in the United States that continue to participate in the trial. The slide comes from the company. I'm not the person who put Jefferson at the top, but again, I asked them to provide some slides for what would you like this audience to know about PHP, and this is what they provided. But this is a big deal. This uses a lot of resources. It takes 2 interventional radiologists, at least 2 anesthesiologists. Patients are on veno-veno bypass, so there's a perfusionist, 2 or 3 interventional radiology nurses in the room to coordinate all the data recording and everything that's going on, 2 or 3 IR technologists, research staff in the control room. It's a production. Finally, I want to discuss microwave ablation. So microwave, it's placing a needle directly into the liver using either ultrasound or CT guidance, and it's using heat to destroy the tumor cells. And we've been using this for patients who present either one with a solitary tumor, and they've shown us over a couple MRIs that they're not quickly developing additional tumors, or 2, we've had a handful of patients where most of their tumors have been controlled by immunoembolization, except maybe they have one that's growing, and calling that a rogue tumor. So again, this is a small experience, but this, like most of these where you see JVIR 2019, these were just presented at the Society of Interventional Radiology meeting 2 weeks ago. But looking at 7 patients with one small tumor, that 4 of them are still hanging out 1 to 3 years without having developed any additional tumors. 3 patients, they did start developing other tumors afterwards, but 2 of them survived out to 2 years. Of the patients with the so-called rogue tumor, meaning one tumor that grows when everyone else is behaving, 1 patient's been doing well and has had no treatment for 3 years at this point. And some other patients, while the tumors did start growing in the liver again, they were able to enjoy a span without any liver-directed treatment. And this is an example of one tumor that was misbehaving that Robert Adamo ablated, and here's what that patient's MRI looked like more than a year later, and I should have changed that 5.5 because that's now much longer. So, kind of trying to wrap this up. So, how do we approach patients? And again, this is a very customized approach, but in general, patients showing up at our door with less than half their liver involved with tumor. In general, we start treatment using either immunoembolization or radioactive microspheres, probably leaning more towards immunoembolization with very limited disease, trying to give patients a chance to become one of those superstars who goes on with treatment breaks and prolonged survival. We don't know yet for sure if immunoembolization or surspheres is a better initial treatment. There are some suggestions that it might be better to start out with immunoembolization, but that's going to take some more sorting out. If patients show up with big tumors, we often start off with the drug-eluting beads. If they start off with a lot of their liver replaced by tumor, start off with some form of chemoembolization. Chemoembolization or radioactive microspheres after patients progress following treatment with immunoembolization. But in all of that, what is the role of clinical trials? And certainly, as you'll hear in the next set of talks, the role of GP100, where does PHP fit into this algorithm, and so as I say, this is customized approaches. Going forward, it's helpful if results are for liver-directed treatment are presented with a description of, okay, how much tumor was there when you started, so we can get some stratification of results. Certainly knowing tumor genetics will be very helpful as a predictor, and the pattern of the disease. Again, if we're learning that patients with infiltrative tumors are not going to do as well. Again, that tends to be bigger tumors. When patients just present with a handful of very small tumors, they're going to be well defined. And one thing we're learning is that as opposed to a systemic therapy that treats the whole body, it's very different when you're only treating one part of the liver and then coming back a month later to treat the other part. So it takes that span of time to get the whole liver treated. And if there's some growth on that side that got treated second, that shouldn't be considered failure. So going back to approval for MRIs and that sort of thing, probably need a baseline MRI before treatment of each lobe for patients who are on clinical trials. And with that, thank you very much. Absolutely.
So I think we have time for a few questions. We probably have about 10 minutes or so, and then we're going to switch sessions and allow those of you who want to switch tracks to do that too. But if there are any questions, we can take them.
My question, it goes back to the slide where you talked about 10% of people who just progress rapidly, and 50% superstars who do really well. Mm-hmm. Is it possible to imagine, or is there anywhere there's enough information to take both those groups and then map it onto the genetic information that you have about them to look for patterns?
That's certainly something we would like to look into. We're just at the point of identifying that distinction, showing that it even exists. Those are next steps. It takes a lot of time. But you're absolutely right. I mean, it would be so helpful if you knew, but we don't yet. And unfortunately, we had a handful of patients, kind of around the same time, all of whom developed liver metastases within a relatively short period of time of diagnosis of their primary eye tumor. So I had so I got the idea, okay, you have this cluster of people who do poorly, should we even be treating them? Are they doomed to failure? One of my residents looked at 400 some patients and stratified them between, okay, they developed liver metastases within a year or later. Yeah, my hunch was wrong. It made no difference, actually. And again, we're now starting to get to be able to look back over periods of 8-10 years, and when you start collecting hundreds of, when you've had hundreds of patients come to the same institution, we can start gathering information like that. And my supposition was totally wrong.
So I'll just comment. So it doesn't. So the problem is, I think.
Can you give her the microphone, please?
Semi-raspy wood. So I think with our. Oh yes, sorry. Marlena Orloff, medical oncologist. Work with that guy.
She's stuck with me for a while.
So there are some newer mutations that have been found. You heard, I think, a little bit about IFAX and SF3B1 that Dr. Matarin put up there that have been implicated in either a more atypical presentation, so actually more non-hepatic metastasis, or actually a more favorable kind of outcome and survival. But those mutations, I think, in many ways are more recently being studied. So going back, the last couple of decades, we don't have that genetic information on all of our patients. But when it comes to primary eye tumor genetics, whether it's monosomy 3, AQAM, being class 2, you know, some patients say, okay, well, if I'm class 2 in the eye and I develop metastatic disease, is my metastatic disease course going to be more aggressive than if I were a class 1 who developed metastatic disease to the liver? And it doesn't necessarily always pan out that way. So like Dr. Eschelman was saying, you know, we can see 3, you know, to 5 new metastatic patients a week sometimes, and, you know, they may all have a similar size tumor in the eye, may have had similar genetics, may have metastasized at a similar time interval, you know, from the time of their eye diagnosis, and actually present with a similar amount of liver disease, liver burden, and they may all have completely different disease courses and respond differently to first-line therapy. So I think there's a lot of you know, whether it's a mutation or something else. You know, we'll talk a little bit about kind of epigenetics, which is not directly just the mutations, but there's parts of your body that actually then manage the genes, you know, that may be at play that actually alter patients' responses to therapy. And that's, you know, we're just talking about liver-directed therapy, but let's not forget you're going to hear a lot about immunotherapy and targeted therapy, and I think we still just don't know what else is at play that's really dictating patients' outcomes.
Thank you.
Is your decision to use SIR-spheres over TheraSpheres based on clinical outcomes, or is it just because Thomas Jefferson already uses SIR-spheres for other hepatocellular cancers?
Recognize that the indication for the labeled indication for SIR-spheres is for metastatic disease. The labeled indication for TheraSpheres is HCC. It is when these trials were started, it was yet even more cumbersome to use TheraSpheres for metastatic disease, which the manuscript that's under review now was treating patients from November 2011 to January 2017. So you can imagine plans for that trial started at least 2 years before that time. I'm not sure that one is better than the other. I mean, certainly the radiation emitted is the radiation emitted. May there be some theoretical benefit to administering a lot more tiny particles with SIR-spheres? Maybe, don't know. I think the answer is we have experience with SIR-spheres, and that's what we have continued with. I don't know that one is better than the other.
So one last question. Okay, thank you, Dr. Eschelman.